T-CAIREM Trainee Rounds session of the 2026 Summer Research Program. We've probably all met again, but my name is Julia, and I'll be hosting and adjudicating today's session. I'm an MD PhD student at the University of Toronto and a T-CAIREM trainee affiliate. I will be adjudicating today's session along with Dr. Alex Mariakakis. He is a T-CAIREM faculty affiliate and an assistant professor in the University of Toronto Department of Computer Science, as well as an affiliate scientist at Kite Research Institute at UHN. He leads the Computational Health and Interaction Lab, which uses technologies such as smartphones, wearable devices, to develop innovative mobile health applications. And a quick note before we begin, as you've heard, today's session will be recorded and we will be posting it to the T-CAIREM website. We will be hearing from two trainees today. Each presenter will have about 20 minutes to present, followed by 10 minutes of questions. We will begin with questions from the adjudicators, and then we will invite questions from the audience if we have enough time. Our first presentation will be from Austin Barr. Austin is a medical student at the University of Calgary and a co-founder of the university's Artificial Intelligence Society. His research focuses on generating high-fidelity synthetic clinical data. Before medical school, Austin served as a program officer at the Canadian Institute for Advanced Research, where he contributed to the Pan-Canadian Artificial Intelligence Strategy. He has also worked in clinical research at Sunnybrook Research Institute and holds a Bachelor of Science from McMaster University. While at McMaster, he contributed to the design, implementation, and teaching of an introductory artificial intelligence course. Today, Austin will be presenting Diffusion-Generated Synthetic Neuroimaging Enables Transfer Learning for Anatomical Landmark Localization in Low Data Settings. Austin, whenever you're ready, feel free to share your screen and start your presentation.
Awesome. Thank you so much for that introduction. I really appreciate it. I'm just going to share my screen here. Okay, is it sharing okay? Perfect. So hi, everyone. I'm Austin. I'm a final year medical student at the University of Calgary. I'd like to thank T-CAIREM for the opportunity to present today. I've followed these presentations over the past few years, and it's been really fantastic to see the breadth of work taking place at institutions across the country. Today, I'll be discussing our work on developing synthetic neuroimaging data and evaluating whether it can support model training under low data settings. So I'd like to begin with a brief thought experiment. So 3 of these cervical spine X-rays that you see on the screen are synthetic, and 1 is real. So I'll give you a moment just to take a look at them and decide which of the 4 you believe is the real patient radiograph. And then keep your answer in mind, and we'll return to it shortly. I'll just give you a second, and then I'll advance. Okay. So imaging research is very often limited by the availability of imaging data. Imaging data sets are frequently small, particularly in neuroimaging. Patient volumes are unevenly distributed across institutions, and images vary between centers, scanners, acquisition protocols, and patient populations. Even when relevant data exist, REBs and data sharing agreements can be cumbersome and slow. In fact, one case study we reviewed reported an average wait of 8 months to obtain neuroimaging data through cross-institutional requests. And so the question is, how can we make imaging research more accessible? So one solution to this problem that we've been exploring is high-fidelity synthetic data. So first of all, what is synthetic data? So synthetic data is artificial data which is generated to retain key properties of real-world data, but with the intention of preserving patient privacy, because it isn't directly linked to real patient records. And so because synthetic data is artificial, it isn't necessarily subject to the same restrictions or steps to access, share, and use this data as you typically encounter with real-world data. And this data can take many forms. It can be tabular data, text-based data, or really any form of media, including imaging data, which is what we'll be discussing today. Now, when evaluating the quality of synthetic data, we generally consider 3 properties: fidelity, privacy, and utility. So first, fidelity, or how closely the synthetic data resemble real-world data. And for medical images, fidelity can be assessed qualitatively, so through image plausibility, anatomical relationships or proportions, pathological realism, as well as non-anatomical characteristics. So things like orientation markers on X-rays or acquisition artifacts, embedded annotations, and any other really metadata that's related to visual elements. that are commonly present in these clinical images. And so the other side of it is that fidelity can also be assessed quantitatively using metrics that compare the distributions of real and synthetic images. The second aspect is privacy. So in synthetic medical imaging, this largely entails ensuring that the generative model has not memorized and reproduced images from its training data set. And the third aspect is utility, and that's whether the synthetic data can meaningfully support downstream applications. So in this study, we investigated whether we could generate high-quality synthetic lateral cervical spine radiographs. And we evaluated these images across 4 domains. So the first being expert validation through a blinded review by 6 neuroradiologists and 2 spine fellowship trained neurosurgeons. Second was through quantitative fidelity using Fréchet inception distance. Third being privacy preservation through a nearest neighbor analysis. And then fourth, and ultimately, whether these images could provide a useful foundation for transfer learning. So allowing centers with only limited local imaging data to train models on their own patients. So to do this, we trained a denoising diffusion probabilistic model on a modest open access data set consisting of 4,963 radiographs from the Cervical Spine X-ray Atlas, or CSXA. We trained the model for up to 160,000 steps, saving checkpoints every 2,000 steps. So during training, we monitored both training and validation loss, as well as the Fréchet inception distance, or FID, as I mentioned, which compares the deep feature distributions between the real and synthetic image sets. We selected 3 checkpoints for further evaluation. So checkpoints 34 and 40 were chosen to capture convergence of the loss functions, while checkpoint 80 allowed us to assess whether whether continued improvement in FID or Fréchet inception distance translated into better generated images despite the divergence in loss behavior. So 50 images from each of these checkpoints were used for our validation task. So as I said, 8 subspecialists, so 6 neuroradiologists and 2 spine fellowship trained neurosurgeons completed a blinded review of 50 image quartets. So each quartet contained 1 real CSXA radiograph and 3 synthetic radiographs, with 1 generated from each of the selected checkpoints, so 34, 40, and 80, as I mentioned. And then for every quartet, reviewers were asked to do 2 things. They were asked to identify the image they believed was real, and then to rate all 4 images on subjective realism using a 4-point Likert scale, which you can see on the screen there. So what did we find? So experts could not reliably distinguish the synthetic images from the real radiographs. The synthetic images were statistically indistinguishable from real images. So overall accuracy at identifying the real-world image was 29%. There was low inter-rater agreement, and quality ratings between real and each of the groups of synthetic images showed no statistically significant differences. So returning to the image I showed at the beginning, the real radiograph was the image on the bottom left. And for this particular quartet in our survey, none of the expert reviewers were able to identify it correctly. So high realism creates an immediate privacy question. So what if the model is simply memorizing and reproducing its training data? So to investigate this, we performed a nearest neighbor audit across the generated images and the real CSXA training set. So we used vision transformer embeddings to represent each image in a high dimensional feature space, and then ranked real synthetic image pairs according to cosine similarity. So from this search, we extracted the 100 most similar pairs. We defined visually explicit memorization as the presence of near identical vertebral contours, soft tissue silhouettes, or acquisition artifacts that extended beyond what would be expected from plausible sampling variability. So 2 reviewers independently inspected all 100 pairs side by side, and no visually explicit memorization was identified. We also publicly released these 100 nearest neighbor pairs so that others can independently examine and interrogate this finding themselves. And so displayed here on the screen, you can see 2 image pairs with the highest cosine similarities. And even just on brief visual inspection, I think you can appreciate the apparent differences between these images. So now that we had high fidelity, privacy preserving data, we wanted to evaluate its utility. So the original CSXA images already had vertebral body anatomical landmarks. So we first trained a spatial configuration network, or SCN, on the real CSXA image landmark pairs. We then used that model to assign pseudo landmarks to our generated data set of just over 20,000 synthetic radiographs. Those synthetic image pseudo-landmark pairs were used to train a second landmark localization model from random initialization, and the resulting weights became our synthetic pre-trained backbone. So we then asked whether this synthetic backbone could improve performance on an entirely independent data set. And so for this, we used the publicly available CLX34 dataset, so another C-spine radiograph dataset that's open access, which came from a different institution and included different acquisition characteristics, substantially different pathology. It also included surgical hardware and flexion and extension views. So all features that were not necessarily represented in our original training dataset. So we fine-tuned the synthetic pre-trained model using progressively larger subsets of the external training set, ranging from 100 to 700 images, and compared it with an identical model trained from scratch. And then at every training set size, both models were evaluated on the same independent held-out test set. And so despite the differences in image acquisition, the patient population, pathology, and surgical hardware, the synthetic pre-trained model outperformed de novo training at 6 of the 7 training set sizes, with the largest advantage observed when the least labeled data were available. So this suggests that synthetic pre-training can have meaningful impact in learning efficiency when only limited labeled imaging data are available. So I'll summarize our study with 4 key takeaways. So first being that we showed that diffusion models can generate lateral cervical spine radiographs using a modest training set that experts could not reliably distinguish from real images. Across 8 subspecialists, so the 6 neuroradiologists and 2 spine fellowship trained neurosurgeons, identification was essentially a chance, and realism ratings were not significantly different from those assigned to genuine radiographs. The second key finding was that we found no evidence of visually explicit memorization during our nearest neighbor privacy audit. The third was that after quality control, we released an open access dataset of more than 20,000 synthetic cervical spine radiographs. So we hope this dataset will become a useful resource for education, model development, and further research. The fourth key takeaway, and perhaps most clinically meaningful, is that the synthetic pre-training improved landmark localization performance when external label data were limited, despite substantial differences between the original and external data sets in the imaging characteristics, the pathology, the surgical hardware, and annotation conventions. So taken together, this work suggests that synthetic imaging could lower the barrier to developing models, particularly for centers that don't have access to large local data sets. I'd also like to discuss a few limitations. So although Frechette inception distance is widely used in computer vision, it isn't a radiology specific metric, so it shouldn't be interpreted in isolation. This is why we combined it with expert validation and downstream task performance. Before release and downstream use, the synthetic images underwent quality control filtering to exclude radiographs with obvious anatomical distortions, severe generation artifacts, incomplete visualization of the C-spine, or other clinically implausible features. The pseudo-landmarks used to train the synthetic backbone were generated automatically rather than manually verified. So errors in these labels may have limited the downstream performance of the pre-trained model. And finally, while our nearest neighbor audit found no visually explicit memorization, continued work on more rigorous privacy evaluations remains important. So I'd like to now just talk about a few different future directions. So the first being developing automated quality control pipelines to detect anatomically implausible or low quality synthetic images, which would reduce the manual filtering time, which I mentioned, and enable more scalable generation of high quality synthetic data sets. We're also interested in expanding beyond anatomical landmark localization to more clinically relevant downstream tasks. So in cervical spine imaging, this may include fracture detection, degenerative disease classification, or surgical planning. And then more broadly, similar synthetic pre-training approaches could be evaluated across other imaging modalities, which I'll speak on in a second. And then it would also be valuable to compare synthetic data sharing directly with federated learning. So future work could determine whether sharing high quality synthetic data sets offers a simpler and more practical alternative or complementary strategy for multi-center AI development. So as I mentioned, the next steps in our approach here is to apply this pipeline to other imaging modalities. And so I'd like to just share some of our ongoing work on synthetic MR of brain metastases. And so you'll see on the right side of the screen there 4 different axial volumes of brain MRs for brain metastases. And so we've been developing this novel approach to 3D image generation using a similar pipeline. And so we've produced these axial volumes with single generation. They have slice continuity. And as you can see, they have diverse tumor morphology. And these span through T1, T2, FLAIR, and T1 contrast enhanced images. And these images can be directly converted to NIfTY format for segmentation, which we'll be working on. So I'd like to thank you all. I'd also like to thank a number of my co-authors. So I'm especially grateful to Dr. Sutherland for his ongoing mentorship and guidance. A big thank you to Dr. Sanju Lama for her tremendous support with this project. I'd also like to thank our expert reviewers and close collaborators, Dr. John Lissac, Dr. James Scott, Dr. William Morrish, Dr. Munir Issa, Dr. Morgan Wilson, Dr. David Cadote, Dr. Michael Yang, and Dr. Ian Chan. I'd also like to thank Dr. Bridge Carmer, Dr. Eddie Gao, and Anthony Winder for their important contributions to this work. And thank you all again very much for listening, and I'm happy to take any questions.
Well done, Austin. That was an amazing presentation and a very interesting application of synthetic data with very promising results. Dr. Mariakakis, do you want to begin with the questions and then I can jump in after?
Yeah, so Austin, good job. By far, I think this was one of the better presentations in terms of like introducing and setting up the problem. So I really appreciate that. I got can you go back to the quiz question you gave at the beginning with the 4 images?
Yeah. Did you get it right?
I got it right, but I may have cheated because I was looking in the top right corner of the images and I see the letter R, and the letter R looks very clean in that bottom left image versus the other one. Do you think other people picked up on that, or was anything like regarding artifacts maybe could have confounded maybe how people did this?
That's a great question. I think so. If you take a look at the sort of the occipital lobe there, you can see that there's kind of skull over the right-sided letter on each of the other images.
Yeah.
But if you actually go through the data set of the synthetic images, there's actually a fair number of images that do show that R. And so in terms of different kind of metadata that's coded into the images, it actually was captured quite well in the images, but that was certainly a very astute observation on your behalf.
I just got lucky. No, it's fine. And then I don't have too many questions. The other main question I have, so you're assessing realism, which is a good start, and you acknowledge the fact that you do want to take the next step from going from the landmark detection to these more clinically relevant problems.
Correct.
There is a potential risk, and I don't know if you've seen this or if you've thought about this yet, where you can have something that's synthetically generated that's real, but the ability of these models to generate real or seemingly real images might be biased in particular ways. So, for example, maybe the model is good at synthetically generating normal radiological images, but it does a bad job of doing that for abnormal situations. And maybe, like, I've run into a situation where we were doing some sort of deep learning model that it wasn't doing synthetic generation, but it was doing signal reconstruction. So basically take a signal, try to pre-process it to make it look like another signal. And one of the questions I got that was very valid was that, if the model's just learning what a typical image looks like or a typical signal looks like, as long as that looks real, then it's going to pass the realism check, but it's not going to be useful for a downstream clinical task where you want to preserve artifacts. You want, artifacts that are real, but clinically relevant versus artifacts that make it seem not real. So I'm not wording the question well, but I'm curious if there's a way, or if you've given thought to looking at the realism maybe stratified across different types of images, so like a completely normal image versus one with lots of abnormalities.
That's a great question. So I have a few different thoughts kind of in mind for that. First, being, I guess, the first being was that this data set in particular wasn't particularly pathologic from a radiographic perspective. And so it's hard for us to say, because the easy way of doing this is, you have readers look at it and say, is this benign or pathologic? And then you can look at proportions between the real data set and whether it's preserved in terms of proportionality for the synthetic data set. So we didn't necessarily do that analysis in this particular study, but I'll mention 2 points that I think may capture some of what you're mentioning. The first being is that despite the fact that even though the synthetic images we didn't necessarily look at capturing pathology within it. When we applied the pre-trained model to a data set that did have a significant amount of pathology and surgical hardware and flexion and extension views, the pre-trained model still outperformed data that was trained with, the data from that external data set that was trained just de novo with that. So I think that there is still applicability, even irrespective of whether or not it's captured. And the second thing I'll just mention here is that if we go over to kind of our present work in terms of the brain MRs, certainly we haven't gone through and asked the neuroradiologists yet to say whether these metastases that appear in these axial slices are morphologically correct. And I mean, in general, metastases can really take on any form in the brain, but it does show that there is a capturement of pathology in these images, which I think is promising. But nonetheless, I think with this next work is where we'll really capture, whether we're adequately, demonstrating that we can have that pathology aspect in our synthetic images. I hope that answers kind of what you were.
Yeah, no, that's good, and that's all for me. Thanks.
Yeah, no, thank you very much.
Austin, yeah. So just to, I guess clarify, I had similar questions to Alex, but I was wondering because Alex was able to recognize potentially this R being a little bit more clear. Did you notice that any expert reviewers maybe found a particular problem with certain images, like if they were able to identify a certain set of images better than other sets, and whether that corresponded to a weird anatomical abnormality or a rare case or something like that, any patterns that the reviewers were able to notice?
So we did leave a comment box. There wasn't really much that was given to us in terms of, kind of qualitative feedback. I'll just mention very briefly, just because I didn't say this previously, some of these are synthetic on this page, and so you can see the R's in the corner as well from the synthetic images. But just going back to sort of the idea in terms of whether there was there was variability in terms of performance. So if I go back to this example, all 8 of the assessors didn't get this question right for whatever reason. And I think it would be helpful to, in further trials, particularly perhaps with the brain MRs, that we do capture more of that feedback in terms of why they may have been mistaking things. But aside from kind of looking at inter-rater agreement and performance overall, we didn't. I don't think we dived in in too much depth to any particular patterns in terms of why people got things wrong. With that being said, I'll just mention one other thing. So we generated that very large scale data set, and I'll just pull this up here. So we generated essentially 27,000 images. And then we did quality control on the images, and so it did remove a large number of the images when we went through them. And so some of those images perhaps that we presented to the reviewers may have just not been as strong as some of the others, and that's that's okay. But I think as I mentioned in kind of the future directions, one of the things that we'd like to do with this is to have kind of that automated quality control mechanism, so it's not a manual process. And I think with automation, if we get that better, then perhaps we may not see as much variation in terms of performance, and it may be even closer to just chance from 29% to closer to 25%.
Awesome. Yeah, that was also a follow-up question I had about how many of the synthetic images were you removing per batch of generated images. So yeah, thanks for the quality control table. And I guess a final question I had is from my understanding, MRI scanners and images are very hard to like I guess bring into the same type of units because every MRI scanner has different types of properties and different ways of like measuring things. So like
Mhm.
what kinds of challenges are you anticipating from like maybe making this synthetic batch of MR scans clinically like meaningful or I guess diverse across different scanners? Like how are you standardizing this process and making sure that it can be applied to like maybe transfer learning for like all MR images, if that makes sense?
Yeah, it's a really difficult problem, and that's why it's still ongoing work for us. So I think with all of the synthetic work that we've been doing, both from a tabular perspective and also from the imaging data that I talked about today, really it's just been a progression. And so we've been, we say, okay, what's kind of the minimum viable product that we can demonstrate, and that was the case for this was the cervical spine. We wanted to show, chest X-ray is, there's huge amounts of data out there, and so we wanted to try with a more modest training sample, and so we started with the cervical spine. And then essentially, we show that we can, foundationally do that. And so now we're kind of moving on to a more complex problem. And so in my mind, at least, kind of the biggest challenges with the MR of the brain metastases will be, um, you know, uh, so when we were generating these axial slices, it's much less homogenized in terms of the number of slices that you have in MRIs. And so what we did was we standardized to the same number of slices. That was essentially the common denominator that had the most amount of within the data set that we trained on, that had the largest kind of common denominator in terms of number of slices. And then trained on that. And so we won't necessarily, based on the approach that we're currently doing, necessarily get the full capture of all of the training data from that. And so that's obviously a limitation that we want to work on. And then I guess the other aspect being is kind of generating, so these are axial slices, but obviously we also want sagittal and coronal, and kind of co-registration of the three of them together in generation. So I think those will be kind of the next things that we capture.
Awesome. And I think we have time to squeeze in one more question from the audience. Sina was said, fantastic presentation. Can someone make a customizable X-ray with this, like generate an X-ray of a 70-year-old with C3 fracture and surrounding soft tissue swelling? I can begin to imagine the medical education application of this model.
Yeah, it's a fantastic question, and I really appreciate the compliment. Thank you. Um, so actually, there was a paper that came out, and I apologize, I don't have the link on hand, but that they were prompting diffusion models for generation. I haven't played around with it. It very recently came out, and so if you leave your email in the chat, I'm happy to share that paper with you. I can go back and look for it. It's on my mind to also look at it again. So at present, in terms of the model that we've used, it's very much a random process. And the randomness is also very much beneficial from a privacy standpoint. But obviously, yes, there isn't much in terms of control on our part that we can do in terms of saying, we want these specific images captured and generated. But I think that is where the future is headed in terms of diffusion generation. So yeah, if your email is in chat, I'm happy to share that paper with you.
All right. Thanks, Austin. That was a great presentation, and thank you so much for the engaging discussion.
Thank you very much.
So yeah, now we'll move on to our second presentation by Valentina Tamayo Velasquez. Valentina is a PhD candidate at the University of Toronto's Institute of Medical Science under the supervision of Dr. Bernard Lafall and Dr. Andrea Waddell. Her research focuses on the development, implementation, and adoption of artificial intelligence and machine learning technologies in mental health care settings, with particular attention to patient safety and clinical outcomes. Her thesis examines the development and implementation of the predictive risk identification for mental health events tool, known as PRIME. This work combines the development of a machine learning model for predicting mental health specific adverse events with stakeholder engagement and the co-design of appropriate clinical response strategies. Today, Valentina will be presenting Bringing AI to Psychiatry, Developing and Implementing an AI Prediction and Alerting Tool for Psychiatric Adverse Events. Valentina, feel free to start whenever you're ready.
Hi, everyone. Thank you for the introduction, Julia, and thank you for having me. I'm really excited to present today my research. So I am a fourth-year PhD student at the Institute of Medical Science at the University of Toronto. And as Julia mentioned, I'm here to present my work around the PRIME tool. So just going to make sure you guys can see my screen and hear me. Perfect. So first, I will give an introduction and some background regarding the literature around my work, and then I'll discuss 3 connected research studies, followed by a brief conclusion and outline of some next steps. So for some background, Waypoint Center for Mental Health Care is a large psychiatric hospital located on the Georgian Bay in Penetanguishene, Ontario. It is a 315-bed psychiatric hospital that operates mental health, addiction, forensic psychiatry services that offer different programs for different patient populations and needs. So the forensic units do have high-risk patients and a high rate and prevalence of adverse events, allowing us to explore the possibility of developing a model to predict these adverse events. So the question I ask is, why does early detection of mental health deterioration matter, and how can AI help with this? So when we talk about patient deterioration in mental health, we're referring to a significant decline in a patient's mental state that can lead to safety concerns or adverse events. Some common safety incidents in psychiatry include increased aggression, violence, self-harm, harm to others, or injuries. And in some cases, these situations can escalate to the point where interventions such as restraint and seclusion are used. In mental health and psychiatry, preventable adverse events continue to be a major concern, affecting both patients and staff in terms of safety and patient outcomes. And this highlights a specific gap and a need for proactive and data-driven approaches to improve both safety and patient outcomes. So despite several advances in predictive models in other areas of healthcare, there's still limited research applying these types of tools to predict adverse events specific to mental health and psychiatry. So one approach that has been widely used in healthcare is the early warning system, and these tools are designed to recognize early signs of clinical deterioration with a purpose of triggering timely intervention or activating a rapid response from the clinical team. And these early warning systems typically work by assigning a score to a set of clinical parameters, which then generates an overall score or risk prediction score. And research shows that patients often display early signs of deterioration up to 24 hours before a serious clinical event, which creates a window of opportunity where these early warning systems and potentially machine learning-based predictive tools are now emerging as promising methods to prevent further deterioration and to prevent these adverse events. And so currently we do have some tools that are mostly assessments and checklists available to physicians in mental health that help them quantify when a patient is at low risk, moderate risk, and high risk for certain adverse events or certain negative outcomes. And so we have the Broset Violence Checklist, Historical, Clinical, and Risk Management, the Dynamic Appraisal of Situational Aggression, and at Waypoint we have a tool that was made called the Acute Risk for Violence Scale. And so there is still insufficient research, as I previously mentioned, on predictive tools for adverse events in acute mental health. So we thought, why not use a machine learning tool to leverage the large amounts of data we have and reduce the clinical workload to serve as an additional support tool. And so to contextualize the scope of my research, I want to outline these 3 core concepts. So first, we were interested in the development and evaluation of a machine learning model to predict adverse events. Second, we wanted to pilot the model for feasibility and preliminary safety. And third, we want to take a human-centered approach to implementation by understanding the stakeholder readiness, concerns, and requirements and addressing those, as well as by creating a co-designed response strategy and approach for the machine learning-based alerting system. So from this work, we then hope to move to a clinical trial and move to clinical implementation and adoption. But for today's presentation, I'll focus on these three core concepts. So first, for the model development, we had to determine which key factors could contribute or do contribute to the detection of patient deterioration in order to include those variables in the model. So to do this, we conducted a scoping review to search all the literature of risk prediction models, both machine learning and non-machine learning based models that had been developed in psychiatric settings to explore what kind of variables were included in all of their models. We also had meetings with the project team, which included physicians, nurses, clinical managers, informatics specialists, and members from the patient, client, and family council. And then from there, we matched which of these variables that we had brainstormed. We matched them with the variables that were available within the hospital's electronic medical record, as to not increase the burden on clinicians to record new or collect new data. We wanted to use data that was already available. And so in terms of the sample and the data that we did use, we retrospectively retrieved 50 data variables from the EMR from patients at Waypoint between January 2020 to August 2024, which included over 4,000 patients on both forensic and non-forensic units. And this included static and dynamic elements, which are captured by the diagram on the left. Some examples of the data were pulled from the activities of daily living, the inpatient admission assessment, suicide risk assessment, the incident log for previous data on adverse events and incidents, vital signs, diagnoses, and mental status assessments. And so in collaboration with a team of experts at York University, we were able to develop 4 working models to compare for best predictive performance. We trained and tested 4 models with the data from 2020 to 2023 and divided this into training and test data sets. And we assessed the model's performance on 2024 data. And so as we can see, the performance is on the left side. The long short-term memory model, the LSTM model, was the best performing model with an AUC of 86%. And so for a bit of context, the LSTM is a time series model that takes time-stamped data to forecast time-sensitive events. And so, as I mentioned, we ended up naming this tool the Predictive Risk Identification for Mental Health Events, which is a mouthful, also known as the PRIME tool. And the PRIME tool has a 24-hour prediction timeline. So in line with what I previously mentioned in the introduction, that 24-hour gap and critical period for intervention. And so when we evaluated the model with 2024 data, so from January 2024 to August 2024, the model resulted with an AUC of 83%, precision of 32%, and a recall of 32%, which I'll get back to in a future slide. But right now, essentially, we have a tool that is really sensitive, which aligns with the clinical utility as an additional screening tool. And so in terms of piloting the PRIME tool, to further evaluate the PRIME tool, we conducted an early pilot study where we had 2 phases. The first phase of the pilot study began in January 2025 with one psychiatrist receiving daily alerts from 8 a.m. to 9 a.m. before he began his clinical rounds. And this daily alert included a list of predicted patients flagged for at risk of deterioration from the PRIME tool. And then in April, we onboarded a second psychiatrist for the pilot. And so all of the daily alerts that were sent out to the physician were accompanied by an end-of-day survey via REDCap. And this survey was used to assess physicians' perceived utility, perceived accuracy, and overall the implementability of the PRIME tool. And so from the pilot, there were a total of 142 positively triggered alerts with an average every day of 2 to 3 alerts per day. And so this bar graph displays the physician's perceptions. So we see for 36% of the alerts that were sent, the physician agreed or strongly agreed that they were useful. And for 30% of the alerts, the physician agreed or strongly agreed that they were accurate, which, if you remember, is pretty in line with the precision, which was 30% of all of the alerts were correct. And so, not shown here, the survey also gathered some other data, and the physicians did express a high degree of satisfaction with the alerting process and expressed that the number of daily alerts was reasonable, so no physician alert fatigue. And so currently, where we are now is that we're piloting, we're running a Vanguard pilot study to answer the question, is it feasible to deploy the PRIME tool in inpatient mental health settings? So the Vanguard design minimizes system risk while estimating the physician adherence and operational feasibility before scaling to a clinical trial. So this study will use a crossover design to deploy the intervention for 3 months during the intervention period, followed by a 2-week washout period where the physician will stop receiving study alerts in order to return to baseline and minimize the carryover effects from each period. And then there will be a 3-month non-intervention period, and there'll be crossovers. The primary outcome we are interested is the physician adherence as measured by the acknowledgement of the daily alerts. And secondary outcomes include safety of deploying the tool, physician workload, and trust in the tool. And so, as I mentioned, we are also interested in contributing to understanding and addressing the key stakeholders' needs. And so, for a little bit of background before I jump into that study where we do that, artificial intelligence and machine learning, as we see, are becoming increasingly common across different healthcare settings. And so some examples of this can include clinical decision support, and risk prediction, such as the one I just presented, wait time and hospital readmission prediction, enhancing operational safety, and personalized and digital health services. But realizing these benefits requires a strong understanding of the implementation context, which is specific to different hospital settings, different clinical settings, and the perspective of the key stakeholders who will be using the tools and will be affected by the tools or supporting these technology and the implementation. So beyond the development and technical performance, literature highlights that the successful AI adoption can't solely rely on technical accuracy or the model performance. So there has been previous work in this area that has looked at healthcare professionals, mostly clinician perspectives and attitudes towards AI technology in healthcare. However, there is a major gap that remains in mental health, patient perspectives, and other hospital staff that are also involved in the process. And so, to summarize, the goal of this next study that I'll talk about briefly, is to explore how patient and staff AI at mental health care, to explore patient and staff perspectives of AI in mental health care settings, and to try and understand their views on implementation, as well as their training and educational needs. And so to do this, we had a mixed method approach where we conducted focus groups with staff and patients both separately and collected some questionnaire survey data. And so in total from the study, we had a total of 21 staff participants, primarily female, in admin roles, nursing, allied health staff, staff from IT and data analytics, some staff from research, and other occupational types. And then we also had a total of 20 patient participants, mostly males, and mostly in our forensic programs. So just to keep in mind, with regards to the forensic patient population, most of these patients don't have access to technology. So we had a very limited understanding, which I'll get into in terms of the results from our discussions. So we identified 5 key themes where staff and patients often discussed similar topics due to the similar nature of the focus groups and questions, but their perspectives did diverge depending on their experience with AI and is reflected through the different sub-themes. So first, we had making sense of AI through current knowledge and experiences. So this was current knowledge and understanding of AI, as well as their current experiences, whether that's personal work or patient care related. Second, we had trust, risk, and differences of AI perceptions. Third, finding a place and role for AI in mental health care. Fourth, worries and concerns towards AI, which was a big theme. And fifth, preparing for AI through education, resources, and strategies. And so to summarize, this slide summarizes 3 themes that most differed between patients and staff. And we found some considerable variations among the participants. So the first theme was the level of AI knowledge and familiarity. So with staff, we had a higher and broader knowledge around AI and experience with AI tools that felt most of them were relatively comfortable with technology, while patients, on the other hand, had limited exposure and expressed uncertainty about AI systems and how they work and how they might be integrated into clinical practice. So for the focus groups with the patients, we found this as an educational opportunity. Second, we found for the theme of preparing for AI through education, resources, and strategies, participants consistently emphasized the need for training and ongoing support before the tools were implemented. Sorry, staff participants. And staff participants also highlighted the need for super users amongst their clinical teams for the rollout of AI technologies. Patients, on the other hand, wanted more simple and accessible materials, more hands-on experience, and a lot of them, surprisingly to us, expressed the need for shared learning. So a shared learning and open discussion with the staff and their clinical teams. And then lastly, for the worries and concerns, the staff discussed more often professional and systemic concerns, while patients highlighted personal and relational concerns. So a lot of them were worried about less time with the clinical teams and with their nurses and staff. And so some recommendations from this work and the work we've been doing with the PRIME tool and AI implementation in mental health care was to focus on implementation strategies, not just performance, and as well embed transparency and explainability when possible throughout the whole process from development to implementation, and to use more of a AI first and human second approach. And so I'll have one slide on our next steps. We're currently working on a co-design strategy where we're inviting clinicians and patients to participate in a study where we ideally want to co-design a response strategy for the PRIME tool. So right now the alerts just get sent out with the list of patients, but we also want to provide a co-designed response strategy and response pathway for the clinical team to use. So with that, thank you for listening, and I do want to thank my awesome team of collaborators, supervisors, committee members, and my mentors, and I'm happy to take questions.
Thank you, Valentina. It was a really interesting combination of like interdisciplinary research for AI. Well done. Alex, do you want to begin again and then I can hop in after?
Sure, and then we should also make sure we get the one in the chat. So Valentina, wow, a lot of stuff in there. It's going to be hard to get all of it, but kudos to you for doing all this over the course of the past few months. So I probably won't be able to cover all this. I'll ask some very light technical questions. So with the machine learning models that you developed, you mentioned like an 80-20 split, and then you jump to accuracy. Can you just talk a little bit more? Like, are you doing the split? Like what I guess what's the data setup like in the sense that is each patient treated as a single sample? Do you have multiple samples for each patient? How is that splitting and modeling being done?
Yeah, we did 2 approaches. this was a while ago. So I know we did two approaches where one was held out and held and within patient approaches. So the first one was we did a split between um, the years. So patients were recorded um, more than once in both the training and test set. And then another one was where we did a split with number of patients, where the
Mhm.
patients, some of the patients were only captured in the training, and then we left some to be captured in the test set.
And based on the fact that you presented the one that was split by years, I take it that that was the better one, right?
Yes, yes, yeah.
Okay. Yeah, so if that's the case, then how would you imagine deploying this? Because what the implications of that would be is that, there is this assumption that you have basically training data for each new patient that comes onto the program. So have you thought about how that aspect would be implemented?
Yes, so throughout since I guess we piloted from January 2025, we have been continuously monitoring the model performance to make sure with all the new patients that the model performance doesn't decrease.
Hmm.
And that's something we're continuously trying to, or continuously evaluating, as well as doing some side additional analyses.
Okay,
Um,
so if I understand correctly, so you've tried the different training and testing configurations, but regardless of which one worked better, you took that model and you're using it prospectively in the pilot
yes,
study without necessarily having training data like novel training data from the new individuals. You're just deploying it for evaluation.
yes.
Okay, cool. Um, and then you touched on this to some extent, but I did want to touch on it again. You mentioned like a 30% precision number somewhere, and I don't remember if you talked about like sensitivity and specificity or precision recall earlier. Did you have any other slides that were splitting up the notion of false positives and false negatives? I might have missed that a little bit.
So I have the
Ah,
precision, the recall.
okay. Okay, yeah, sorry, I missed the one in the bottom left. I was probably taking a note in the
No,
background.
no
Okay, so
worries.
this is good to see. At a high level, could you just talk through for this particular implementation the cost of a false positive and a false negative? Like you mentioned false alarms and like disruptions a little bit, but can you talk about that a little more as well as like what are the implications in this context of a false negative of missing an event?
Yeah, so for the false positives, uh, we did collect a bit of data on that on the pilot from the physician, and they were, it was on an implementation perspective, it was okay in terms of it just prompted them to check on the patient anyways. And a lot of the clinicians we have a ton of patients. So in terms of the prioritization, it kind of helped them prioritize the list of patients that they were going to go and check in on. In terms of the false negatives, that is something that we are trying to improve so that we don't miss a lot of the positive events. Uh,
Mhm.
so currently the tool is catching about one in three of all deteriorations, which we would like to get that number a bit higher,
Sure.
but I don't
It's a
have
hard
any
problem.
data. Yeah, I don't have any data in terms of implementation regarding the implementation for the false negatives.
But you brought up an interesting thing. So yes, at worst, if you have a false positive, a clinician could just use it to kind of up a priority. Did you find or do you have data to about the extent to which they like did they always follow up on these alarms and reach out to a
Yeah,
patient, or was there like a buffer period where it's like, oh, I followed up with them yesterday, so I'll just leave a note, but I'm not going to follow up on this particular alarm.
yes. So in terms of actions taken, for all of the alerts that were sent, 70 for 71% of those alerts, the physician did take action. Within those actions taken, it was the most common one was increased monitoring and checking. So there was times where um, if they themselves didn't go check on the patient in the notes from the REDCap survey, they asked the clinical team to check in at some point within the next day or two. And then they did document the alert so that the rest of the clinical team would take note of that. But for the most part, they did check in. And I would say, just from what I remember from the data, the ones that they didn't, click that checkbox of increased monitoring and checking, there were patients that had alerts go off consistently for like 3 days at least.
Mm-hmm. Okay, no, and this slide is very helpful, so I appreciate it. Thank you.
Thank you, Alex.
That's it for me.
Valentina, I had a question about missing data. Sometimes, things aren't included. So how did your models deal with that?
So all of the variables that we did have in the model from the EMR were, we ran into that issue early on when we had like a list of 100 variables that we did want to include in the model, but the data quality was not very consistent, not very good, and there was a lot of missing data. So we kept reducing the list of variables to only include variables that were mandatory to be done at least once a day. So all of these variables, I think, were mandatory to be logged within the EMR. And then in terms of missing data prior to we did have a lot of missing data prior to 2020, which is why we just decided to just start at 2020 when all of these variables were mandatory to be filled out within the EMR. So there wasn't any, in terms of like missing data from these variables, there wasn't much missing data. There was a lot of missing data in the beginning when we were deciding and playing around with
Yeah,
all the variables that could be included.
that makes sense. And another question I had was, like you mentioned, you only had like, I guess, a set amount of variables. Do you know which ones contributed the most to the model prediction? And like, does that kind of coincide with clinician intuition, which kind of leads into the question from the audience, which I'll ask after?
Yeah, not, yes, we know, like, in terms of the feature importance, we did. I don't have a slide on it, but I think I remember it was um, diagnoses was first, prior incidents from the incident log was second, and I can't remember the third, which I think the only one from there that coincides with physician intuition is the prior incidents. So like if the patient had
Mhm.
an incident yesterday or in the past few days, or like has incidents and is pretty common. That's the only thing from the list that was like uh, helpful. Like if we were to show the clinician, the rest were kind of random. Um, and then did you have a second part of your question?
Yeah, I'll bring up the audience question now. So we have a very interesting presentation. I wonder if you can comment on how this model compares to clinician intuition. So, for example, does the model consistently flag a set of patients who are known to be aggressive or suicidal? Or are there cases where a psychiatrist says, wow, I really did not see this safety incident coming, but the prime tool did?
For the most part, it does like when we talk and we check in with the physicians and we check the surveys, it does like go hand in hand with their um, clinical experience with those patients. So it is usually patients that they're well aware of that have had, or when we talk to them, they're like, oh, yep, this makes sense that those patients got flagged like um, with what they saw. Sometimes it's not that they can, um, not that that physician can predict as well as the prime tool, but then so if they get an alert at 8 a.m. and they fill out the survey or we check in with them after the day, they then like write comments on what they observed. That does coincide with the alert. There's very few, like, I would say very few times when it's a surprise. But there have been incidences where at the beginning of the day, the patient, I think there was one instance where the patient was going to be discharged, and then throughout the day, they showed signs of deterioration. And so the alert ended up being correct. And at the end of the day, that's what the physician reported. But I think it's only a very small percent.
Interesting. Yeah. Thank you so much, Valentina. And thank you again to Austin, both of our outstanding presenters. I feel like I learned a lot, and I hope everyone else in the audience also learned and saw different ways that AI can really transform medicine. Also, big thanks to Alex for joining me today again, and for everyone in our audience for being so interactive. And a reminder for the summer students, the in-person mini conference will be taking place on Monday, August 10th at 1 p.m. Eastern Time. Have a wonderful afternoon, everyone. Take care.